DeSouza giving an ACLS update.
Yeah. We got plenty of time. I thought I was going to start at 11:15. Go nice and slow, ask a lot of questions. All right, so you guys all know me. You guys all hate me. It's great. It's cool. I'm fine with that. I'm going to just I was asked to give an update on ACLS. Now remember, ACLS is for, it's for physicians who aren't experts in resuscitation, and hopefully by the time you graduate, you guys will be experts. But it's good to go over this because you should know what the guidelines, say about this, about resuscitation, and it's more and more, it's becoming more and more relying on evidence and not as much commercially driven as when I first learned it. So what I'm going to do is we're going to talk about, we're going to review the algorithms, not all of them because I don't have enough much time. We're going to discuss important concepts and present some of the recent evidence, okay? And then we're going to highlight the guideline revisions. All right, so these are the new and improved AHA class recommendations, okay? They revised this based on, in conjunction with the International Liaison Committee on Resuscitation, and they use the grade classification. So it's more and more evidence-based. And what they did over here was they further qualified their class recommendations based on the quality of evidence that has informed them. All right, so for example, they have, most of the recommendations are level B recommendations, very few level A recommendations, level B and C. So level B is based on good randomized trials or a meta-analysis of those trials. BNR is not based on non-randomized studies, so registry studies, observational studies, or other non-randomized trials that were of good quality. BLD is those same trials, so non-randomized trials that were of limited quality or poor design. And then finally you have level C, which is expert opinion, right? So you'll see these designations in some of the recommendations I put forth in this presentation. All right, so let's go into shockable rhythms, okay? And you guys know all this, right? Shockable rhythms are, right, ventricular fibrillation and pulseless VT, okay? So let's go into, let's do a case. So you have a 75-year-old dude who's got a known history of coronary artery disease. He's brought in by EMS with acute crushing chest pain, crushing. These are his vital signs. So his heart rate's 94, blood pressure 160 over 100. His respiration's at 22, his temperature is normal. You look at the patient and you see that he's got exquisite diaphoresis. Diaphoresis is sweating everywhere. And you're very concerned by this, but you do the rest of your exam quickly. You put him on a monitor, you give him aspirin, and you do an ECG, and that shows large anterolateral ST elevations. Okay, so what do you do next? Right, so you activate your cardiac cath team. You're on the phone with the cardiologist, giving a history that probably doesn't really matter as much right now, but the nurse calls over to you to come see the patient because the patient's now unconscious. And you look up on the monitor and you see this. We don't have patients like this very often, right? Who's had a patient like this? Oh, I guess you do. I need to work more, I guess. Okay, so what's the order of treatment here? What's first? Defibrillation, right? Whoever said airway, wrong. Defibrillation, right? What's next after defibrillation? Good. And the next treatment would be? What? Still wrong. Right, access. So either intravenous or intraosseous access. Intraosseous access is faster, right? And then fourth, finally, which should be really de-emphasized in this group of patients with shock rhythms, you could place an airway. All right? And I would suggest that you place an LMA because it's easier to place if the patient allows you, of course, and because you won't minimize or interrupt your chest compressions. All right, so you get return of spontaneous circulation after defibrillation and chest compressions. The patient's still kind of out of it, so you you remove the LMA, sedate, intubate him, and then he's transferred to the laboratory for emergent percutaneous coronary intervention. All right, so this is the updated algorithm. Okay, there's not a whole lot of changes here, but we're talking about shock rhythms here, so let's start. We're going to go to the left side of the algorithm. So you have a shock rhythm, again, shock. And what's the benefits of shocking these patients? Defibrillation really is very important, right? So survival to hospital discharge is really increased with early defibrillation. And there's lots and lots and lots of good evidence for that. Okay? Time to defibrillation is the biggest predictor of survival. And number two?
High quality chest compressions.
Yes, high quality, guys. High quality CPR. Right. That means adequate rate, right? 100 to 120 per minute, adequate depth, and allowing the chest to recoil. All right. There's not a lot of changes from 2010 when it comes to this. This is probably here to stay. What they do state that is if you have a different defibrillator that you can increase your energy doses, you can escalate energy dose at times of defibrillation. All right? Not stack them, just start at one dose, do round of compressions, and you can escalate the dose if your device allows you to. All right. Now, very important. Advanced airway placement, intubation, LMA should not interrupt or should not delay this initial defibrillation and CPR for shock rhythms. Okay, remember, in cardiac arrest, your oxygen delivery is dependent on what? Perfusion, blood flow, not oxygenation and ventilation, right? So the patient already has some residual oxygen, so you really want to move the blood. If you don't have your defibrillator immediately available, you should start chest compressions. And if you do good chest compressions, if you allow adequate chest recoil, you can get some passive ventilation. You can unload the right ventricle and circulate some substrates, some glucose and ATP, so that when you attach your defibrillator and shock, you may have a higher chance of success. All right, back to the algorithm. You've done your shock, and now you go immediately to chest compressions, right? Okay. During this period of chest compressions, this is when you want to establish your intravenous or intraosseous access. So you're going to perform immediate chest compressions after defibrillation. And it's a weak recommendation, but it's based on limited data. But this data, some of this data is, they found that 50% of patients who have 50% of defibrillation attempts, the post-shock rhythm is asystole, right? So how do you treat asystole? Compressions, right? CPR, right? So that's really what I found is the biggest reason to advocate for this recommendation. Another suggestion, it's not really mentioned in guidelines, is to keep your defibrillator charged. So you start compressions, you discharge your defibrillation, charge it up again immediately, so that when you finish your round of compressions, you can be ready to clear the patient towards the end of the compression phase and then shock immediately and start compressions again. So the key is just to minimize your interruption in compressions, and you can do this eloquently with little subtle changes like this in how you manage these patients.
That just seems like it could be dangerous though, right? I mean, it's kind of like having a gun with the safety off. Like I feel like you have all these people around the patient and there's a chance that it's discharge.
Don't pull the trigger.
It's a good concern. It's a good concern. But remember, you got to push the button, right? So someone is there. You have to rely on your staff, right? Someone is there.
Right.
So it's a valid concern, and that's probably one of the reasons why it's not in the algorithm itself. But you guys are pretty smart, right? So I guess it depends on what staff you have in your resuscitation. But what the guidelines actually say, interestingly, is at the rhythm check, is to resume compressions and charge up during your compression, stop, and resume compressions. That's another interruption.
Yeah, who cares?
Yeah, it's from,
The piece literature shows that you can't get shocked if you're wearing gloves, regular gloves.
Right?
And I think even if you're not wearing gloves, you still need to get shocked.
Yeah, if you're not in contact with the patient with 2 points or something like that, I didn't get into that, but it's really, it's probably the same.
I've kind of found that people freak out about it a little bit, but I tell people, like, don't stop, like while we're charging it, don't stop compression until it's charged, so we're absolutely ready to shock to try to like decrease that time without compressions, because your coronary perfusion pressure is going to drop to basically 0 the second that you stop. So.
Right.
All right, so if venous access is difficult or you don't have it, you should obtain intraosseous access, okay? In terms of access, it's the strongest recommendation they give. Because IO access is associated with there's good evidence for this, higher first pass success and shorter time to placement than central venous access. Central venous access is a 2B recommendation. Where you guys place IO lines, where do you place them? Right. Most of the literature has people place them in tibia, they're more comfortable with it. But the humeral head site might be a better site. Anyone placed in the humeral head before? Attending. That's what I expect is. And the reason why they might be a better site is medications take about only 3 seconds to get from the humeral head to the heart. When it's in tibia, it has to go through the pelvic circulation and all that. So it might be a better site. I think it's a little bit more technically difficult, but there's good flow rates with either site. I think we should start to learn how to do the humeral site, but we'll try to work on that during our simulation. All right, let's switch gears a little bit and talk about coronary perfusion pressure. So your probability of return of spontaneous circulation, which is what you're trying to achieve when you have a cardiac arrest, at least in the short term, it correlates with coronary perfusion pressure. What is coronary perfusion pressure? So remember that the coronary arteries arise from the aortic root, right? So, and the arteries are perfused during diastole, okay? So your coronary perfusion pressure depends on the pressure gradient during diastole from the aorta to the right atrium. It's a kind of maybe a crude correlation, but it's the best we got, or the best it's what the studies have looked at. So coronary perfusion pressure equals diastolic aortic pressure minus diastolic right atrial pressure. And here's an example. This is an animal model. It's a pig who was put into cardiac arrest due to ventricular fibrillation. And there's recordings in both the aorta and the right atrium. And you can see that as compressions are done, it takes a number of chest compressions to build up that pressure, that coronary perfusion pressure, or that pressure gradient. No, I was doing this presentation, I couldn't help but feel sorry for the pig. All right, so here's back to the algorithm now. So we talked about chest compressions, shock to chest compressions. Now you're gonna, after a cycle of chest compressions, you're gonna analyze your rhythm, right? At this point, you wanna get ready to switch the person doing compressions, right? Because they're gonna be tired, the first person's gonna be tired. So you have shockable rhythm, you shock, and you do your second round of compressions, and charge your defibrillator. And here's now, at this point is when you're consider giving epinephrine. Okay, why do we give epinephrine to these patients? What does it do? So one of the activities has alpha-adrenergic activity, right? So what that does is that can increase your coronary perfusion pressure, can increase your cerebral perfusion pressure, and maintain some perfusion to your vital organs, okay, while you're continuing to hopefully shock the patient out of this, right? Or do chest compressions or treat your reversible cause. If you notice, if you can appreciate, they took out vasopressin. So Vasopressin is not, they took it out of the algorithm because in the interest of simplification, because what they found that is when they studied vasopressin plus epinephrine versus epinephrine alone, there was no difference. Or when they studied vasopressin as a substitute for epinephrine, there was no difference in outcomes. So they took it out of the algorithm. Okay, so after epinephrine, this is in shock algorithms. This is the time in the resuscitation where you will consider placing your advanced airway. Okay. Again, I suggest LMA, but it's equal recommendation to intubate. But the key is you want to minimize your hands-off time, minimize your interruption and compressions. A new recommendation also is to use waveform capnography, which I'll talk about a little bit later on. I just want to mention. This trial, this is a trial, a Greek multi-center trial that came out in 2013, which looked at in-hospital arrests, okay? And they found that the combination of vasopressin, methylprednisolone, and epinephrine together had better survival neurologic outcomes than epinephrine alone. They address this in the guidelines by saying you can consider this for in-hospital cardiac arrests, okay? So we have a patient in the emergency department who arrests in front of us, you can consider using it, this strategy. But it's not recommended for routine use yet because they need more data. Anyone have used this before? And no one uses it, right? I put this formulation on the cart and said downstate. No one used it, so. And then we ran out of vasopressin, so there's a shortage of vasopressin, so we removed it. But I want to mention this because this is one of the things that maybe a little more information will come out and we'll start using. Okay, so you've just done your second cycle of compressions. You're going to do your rhythm analysis now. You're going to switch the person doing compressions, getting ready to do compressions. You shock the rhythm, you shock, and you're in your third cycle. You use the rested person to do compressions, charge your defibrillator, and this is where you can consider using antidysrhythmic. Okay, they put amiodarone there. Equal recommendation is for lidocaine. It's a very weak recommendation, but at this point you have shock-resistant VF and pulseless VT, so you can consider an antidysrhythmic. And the point of the antidysrhythmic is to help you restore and maintain a perfusing rhythm in concert with a shock termination of ventricular fibrillation and pulseless VT. But just recently, I got an alert actually last night, there's a study in the New England Journal of Medicine coming out where they did a randomized controlled trial looking at over 3,000 patients with out-of-hospital arrests, shockable arrests, VF and pulseless VT, and they compared amiodarone versus lidocaine versus saline, okay? And there was no statistical difference in survival or neurologic outcomes between the three. So there was a trend in subgroup analysis for the use of antidysrhythmics in patients who have witnessed arrests, but overall there was no statistical significance. So I don't know the details of the case yet. Just was just read the abstract. Keep on the lookout for that study. This may impact our management in the future. And you remember, you guys heard of the OPAL study, right? The OPAL study showed that ACLS, at least for out-of-hospital arrest, ACLS intervention didn't really make a difference in survival with good neurologic outcome. Basically, it showed that defibrillation and CPR were the most important. But, I put this here, what we can do as physicians is, if we can efficiently diagnose and treat reversible causes, and then treat patient optimally with post-arrest care, maybe we can make a difference, and studies will bear that out in the future. But I think this is what we need to focus on, and we do actually, I think, in the clinical area. So let's say you get return of spontaneous circulation. The guidelines recommend use of lidocaine or beta receptor blockers, okay, afterwards, in patients who have cardiac arrest due to shockable rhythms. Remember that lidocaine can suppress premature ventricular complexes and also can reduce the incidence of non-sustained ventricular tachycardia, both of which can presage more malignant dysrhythmias. Beta blockers can blunt your catecholamine surges and also reduce ischemic injury and may have some membrane stabilizing effects. So if you get a patient back and you're in the process now of further stabilizing them, supporting their blood pressure and ventilation, you can consider putting them on lidocaine infusions or esmolol infusions. Question?
I have two questions. The ESMO infusion was people in like refractory defib, right?
Right.
Okay. And the other question I had on the prior slide, do you know if there's been any studies with lopinamide in like unstable decaf?
For pulse system, they've taken that out of the algorithm. From what I understand, presumably because it takes a long time to infuse. The fastest you can really infuse is 20 minutes. So in the interest of simplification, they took it out.
The vehicle's propylene glycol also causes arrhythmias and hypertension.
I don't know the exact reason, but I'll look at it. Send you an email. And then they're just trying to simplify these. And again, antidysrhythmics really haven't shown an impact to survival and neurologic outcome. So the amiodarone recommendation is based on a trial, the ALIVE trial, right, 1999. I don't know if you guys weren't born yet, but there was amiodarone versus lidocaine. Amiodarone had a higher chance of survival to hospital admission, but no difference in survival in hospital admission. All right, any other questions? Because we're going to go to non-shock order.
Yeah.
Yeah.
Ian, so if you're given the amiodarone, they still, and the rhythm comes back, they want you to continue with lidocaine or continue with the amiodarone?
So you can give the amiodarone as a bolus, but they don't make any recommendations after that. So you know, if